All right, well, thank you so much for inviting me back. It really is very exciting to be back here for the 14th time, and thank you as always to Bill and the whole park family for hosting us every year. It's really a very special evening, and I really do enjoy continuing to come out each year and sharing everything that we are doing at MGH with all of you. So the challenge we face is shown on this slide. This shows you the distribution of all the different types of primary gliomas that can happen. And unfortunately, you see that over 50% of these tumors are glioblastoma tumors, which is the most aggressive type of primary brain tumor. And so this is what we're facing. Now, the other challenge we face is that there's been a lot of interest in immunotherapy for other types of cancers, but it hasn't been to date as successful in glioblastoma. And there are a variety of reasons for why there are barriers to immunotherapy success in GBM. One of them is there's a dearth of antigen-presenting cells in the brain. So what this means is that the immune system in the brain doesn't have cells that takes parts of the tumor and presents it to the immune system so that it can turn on the immune system. The other challenge we face in GBM is that there's sequestration of immune effector cells in the bone marrow. So those cells that are the active arm of the immune system stay in the bone marrow and are not in the tumor microenvironment either to activate the tumor immune system. The other challenge is that the treatments that we use for GBM, temozolomide, which is the common chemotherapy we use, and steroids, which we use to treat cerebral edema, swelling in the brain, also cause a decrease in immune cells. And finally, for a variety of other reasons, the tumor microenvironment is very immunosuppressive. These tumors are very smart. They know how to turn off the immune system so that the immune system cannot turn on and fight these tumors. And so our hope is that CAR T therapy is one approach to overcome this immune tolerance. And just to remind you all about how CAR T is done, what we basically do is we take out the patient's own white blood cells, we send them off to the lab to be genetically modified so that they express this chimeric antigen receptor, or CAR, so that's where we get the CAR in the name. And this CAR is targeted to a particular antigen that we can select, and then we grow, expand them so we have enough cells to re-inject into the patient. And hopefully those CAR T cells will then home to the tumor and start to kill the tumor and turn on the immune system within the tumor. And so the CAR T cell therapy that we're using at MGH came out of work by Dr. Brian Choi and Dr. Marcella Maus. And so it's different from a conventional CAR, which targets just a single antigen. And so our CAR targets two antigens. It targets this particular antigen, which is this EGFR-V3. And so the way I think about it, it uses that EGFR3 to home to the tumor itself. And then once it gets to the tumor, it secretes this T-cell engaging antibody molecule, or T molecule we call it. And what that does is it binds to wild-type EGFR, which is another antigen that is expressed by the tumors, as well as T-cell receptors that are sparse, but they are in the microenvironment of the tumor. And so we get this double punch to turn on the immune system. And so we're running this clinical trial, which is the INSIGNITE clinical trial. And it's a non-randomized, open-label phase 1 study. And we're enrolling up to 21 patients with GBM. And we have several arms, as you can see on the slide. We have a safety run-in arm, which we've completed. And then we have 2 cohorts of patients with recurrent glioblastoma, one enrolling both the EGFR-V3 as well as the EGFR, those 2 targets that we're trying to attack with our CAR T approach. That arm recently completed enrollment. And then we're still enrolling into our arm with just has the EGFR amplification, so just that EGFR target. And then we recently opened up a cohort for newly diagnosed glioblastoma patients. And so this is the schema of how our patients are being treated in both of the recurrent arms. So we talked about how patients undergo that leukapheresis, where we take out their white blood cells, send it off to the lab to manufacture the CAR T therapy. Then patients have surgery, and then a special catheter is put into the ventricles, the fluid-filled spaces that everybody has in their brain. And while they're healing up from surgery, the cells are manufactured in the lab, and then they come back in and get chemotherapy. The aim of the chemotherapy is not actually to target the tumor itself, but it's to knock down the patient's native immune system so that when we do infuse these T cells, they're able to expand and grow, and they're not competing with the patient's native immune cells. And this is repeated up to 6 times. And then this is just the newly diagnosed cohort that we just opened, but it's basically a very similar schema where patients also get that chemotherapy prior to treatment, and then the immune cells are infused. And again, this is repeated up to 6 times at about every 4 to 6 weeks. So I'll just give you the summary of the results because I want Dr. Parsons to have plenty of time to talk. But what we found so far is that the treatment is very safe and well tolerated. And importantly, we're able to do these repeated infusions multiple times, and patients are not having any significant toxicity. And what we know so far of these patients in the recurrent arm, of the patients that we have longer follow-up data on, 5 out of the 7 patients have had disease control for longer than 6 months. And in recurrent GBM, that's actually a win, and we need longer time to follow them, but the data to now is really very positive that when we're very cautiously optimistic that we are getting disease control in this patients. And as I said, we're really doing a good job with accrual. We've completed accrual to one of our arms. We just opened the newly diagnosed arm, so we have 6 slots on that, and we only have 1 arm on the other recurrent GBM arm. So we're making slow but steady progress, and again, cautiously optimistic that we're bending the curve a little bit in these recurrent GBM patients. So thank you again to all of you for coming. Obviously, a big thank you to our patients. You know, this is a very intensive study, and our patients put up with a lot to come in and do these repeated infusions. So a huge thank you to them, and obviously to their caregivers who are helping them to get through these trials and really helping us to figure out how to find better treatments and ultimately lead to a cure for this challenging disease. And I'm happy to take any questions afterwards, but let's let Dr. Parsons, who is our main speaker, take it away.
Thank you all very much for having me here tonight. It's nice to take a little field trip up all the way from Swampscott to Marblehead. So I'm pleased to be here with all my neighbors, and it's an honor to talk to you guys tonight about what I do, which as Bill said, is neuropsychology. I'll tell you a little bit more about what the heck that is in just a second, but my job is as a neuropsychologist working within the Brain Tumor Center at Mass General Brigham to provide care for patients with brain tumors and other types of cancer who are experiencing problems with their brain function because of their disease. And for any of you who have either worked with people who have brain tumors or had family members with brain tumors or lived with brain tumors yourself, you know that these are issues that are extremely common for patients. So I'm going to do a little bit of a broader discussion. I'm going to talk about not just research, which will come a little bit more at the end, but also what our program tries to do to help with these brain function issues for people with brain tumors. I'll give you some examples of how we evaluate and understand those brain function problems through neuropsychological evaluation, where those problems come from in terms of the causes of those symptoms, and what kinds of treatments we have available, both in our system and more broadly speaking. And then, as I said, I'll come around to talk about the new directions and ongoing research projects that we have going on in our group now. So to start with, I want to make sure we're on the same page here. You know, the term cognition is a little bit of a potentially jargony term, and it's important to get on the same page about what that means. It really refers to all of your thinking skills. That can include memory, both for recent material and also your past history and learning, your ability to pay attention, concentrate, use of language, visuospatial skills such as visual analysis, design, judgment, and what we call the executive functions, which I'll define momentarily here. It's important to recognize that cognition forms the foundation for many of our daily life activities. And anytime a person experiences a change with memory or attention, it can influence a whole host of activities, including, of course, high-level functions like work and school, but also independence at home, daily activities around the house, your hobbies, and other enjoyable life activities. Those abilities can go all the way down to self-care and interacting socially, without which survival is a limited quality potentially. And so while neuro-oncologists like Dr. Gerstner are trying to desperately find a cure for these terrible diseases that we deal with, our role in neuropsychology is to try to help the people who are living with those diseases and their family to live the best possible quality of life by supporting their brain function. Now, there are many different ways in which brain tumors and their treatments can affect those cognitive skills and abilities. Of course, a tumor in some specific area of the brain can have direct effects on those brain cells that are right around where the tumor is growing, where the surgery is to remove it, where the radiation is targeted. There are also indirect effects by which the tumor can interfere with the functioning of these massive networks of cells and connections that underlie most of our daily function. Those networks mean that a tumor on one side can affect the function of a widespread array of brain areas. In addition, of course, people living with brain tumors also deal with a variety of other problems, such as seizure disorders, medications that they have to take for the chemotherapy or for the seizures. Those all have side effects that can also influence cognition. Fatigue is a common consequence of dealing with cancer and brain tumors specifically, which also influences cognition. And then, of course, the stress of living with the unknowns of a brain tumor, coming back for your scans. Although it's lovely to get to meet with Elizabeth and have her walk you through that, it's pretty scary stuff when you're coming up for those visits. All of those psychological factors also influence the way your brain is working when you're dealing with a brain tumor. The treatments for the brain tumor specifically, while beneficial in terms of slowing tumor growth or reducing the risk of recurrence, have known cognitive and neurologic toxicities. Radiation therapy for the brain tumor, which shown here on this image, is directed at a specific region of the brain in which the tumor may be growing, has negative side effects on the surrounding healthy brain tissue that can lead to brain degeneration, damage to the blood vessels that supply that part of the brain, and gradual brain volume loss over time if you're a brain tumor survivor. And that plays out in initial periods of the first few months, but what many of us worry about, and unfortunately in our clinic see too often, is you may have an effective treatment with radiation that stops the tumor growth, perhaps for years, but the brain injury done from the radiation gradually progresses and worsens, lowering the patient's quality of life and making them more and more dependent on their caregivers. Chemotherapy, as you may have heard the term chemobrain, has its own neurotoxic effects that seem to be less severe oftentimes than the brain tumor effects or the radiation effects, but also can influence cognition in a very widespread way throughout the entire brain. So when it comes to understanding an individual's cognitive symptoms, the starting point from a clinical perspective is what we call a neuropsychological evaluation. And what that involves is a clinical interview with a neuropsychologist like me, as well as an examination of a whole range of areas of brain function using standardized tests. That can include examination of fine motor skills, visual analysis skills, and all of these other domains that I mentioned before. And I'm going to walk you through a couple of examples of those kinds of assessment here and give you a sense for the brain geography that influences those. Motor, sensory, and visuospatial skills are controlled to a large extent by these back areas of the brain here. And depending on the location of a tumor, a surgery, or where the radiation might be delivered, a variety of different motor and visual types of skills can be affected. And we evaluate each of those with different kinds of specific tests that allow us to measure aspects of motor, sensory, and visual function. Within the visual system, we often look for areas of function that are located in this lower part of the brain that have to do with identifying visual objects that you see, recognizing faces, and analyzing fine visual detail. Or tumors that affect the higher areas of the back of the brain can affect more of your spatial skills, your ability to analyze, rotate images in your mind, and do visual analysis of where you are in space compared with some object that you see. All of those are important for navigating visually in the areas around you. Language skills tend to be predominantly controlled on the left side of the brain for almost all right-handed people and about 75% of left-handed people. And language functions are broken into a variety of different abilities, including speech output or language production that you can hear, language comprehension, which has to do with the more receptive aspect of language function, and reading, writing, and spelling, all located in different areas around, for most of us, this left hemisphere. Those are abilities that we evaluate with each person who's having cognitive symptoms after a brain tumor, particularly for those who are experiencing it on the left side of their brain. And for that reason, we often see that for the location of the tumor in terms of left versus right has a great deal to do with the kind of symptoms a person is going to experience, with left-sided brain tumors often being more obvious in terms of the symptoms they present with. Memory is broken into a lot of different subtypes. In general, what we assess and what we worry about most is the ability to learn, retain, and recall new details of our daily lives. That kind of memory in neuropsychological terms is recent memory or anterograde memory. And as a neuropsychologist, we think about 3 steps that need to take place in order for you to be able to make good memories, all of which depend on different brain structures and brain networks. The first step, encoding, is essentially correlated with attention. It's the process you're all engaged in right now, where you're focusing your attention on what I'm saying, you're processing the language information, you're looking at these little flashing images here, wondering what the heck those are. All of that processing of information is encoding, bringing that information into your memory system. The second step is the storage process, and that is taken care of pretty much automatically by this blinking structure here, the hippocampus, which is a critical structure for the formation of new memories. As long as you have the hippocampus doing its job, it is constantly making new memories about what you're experiencing. If you have a brain tumor that influences the hippocampus, maybe it happens to be growing in that area or radiation had to be delivered in that area, then that brain storage process can be affected. It's also the number one culprit that causes the cognitive problems associated with Alzheimer's disease. The third step is the retrieval step, where someone asks you, what did you have for breakfast this morning? Or what did you see on the news today? Or what did that weird neuropsychologist tell you about at dinner the other night? You go back into your mental filing cabinet, you pull out this specific bit of information, and you have the experience of recollection, the sense that correctness of your recall. That's what it was. I remember that. That depends on other brain structures connecting to the hippocampus and accurately identifying the information. One of the most frustrating and troublesome problems that can come about with memory for many of my patients with brain tumors is that the sense of recollection can become disconnected from the memory itself. In other words, a person will think that something is the correct memory, and it feels, for all the world, like an accurate recollection to that person, but it is in fact not an accurate recollection. It can be an invented memory, or it could be that they got pieces of it right, but it's connected to other parts. It's extremely confusing and frustrating for the family to try to help that person sort out what they're remembering is perhaps not real or not quite right. As I mentioned earlier, there are many brain functions that depend heavily on this broad network of white matter or fibers that connect brain areas. And attention, processing speed are very heavily dependent on this very intricate connection network that is throughout our brain. As you can imagine, just looking at this image of all these fibers, brain tumors infiltrate, surround, and grow within these fiber trees. Obviously, when a surgery has to take place, the surgeon cannot separate the cancer cells from these white matter fibers, and they're often disrupted and interrupted. The brain has an amazing capacity to find new pathways through these intricate networks, but they're usually not going to be quite as efficient after a surgery as the network that grew there and developed throughout a lifetime of experience. And so those inefficiencies manifest as problems with attention, concentration, and slower processing speed. Finally, the executive functions I mentioned earlier. The executive functions, as the term implies, are kind of our highest level brain capabilities, our highest level cognitive skills. They include things like reasoning and problem solving, but just like the executive of a company, our brain also has regions that are responsible for dividing attention, shifting between multiple competing inputs, prioritizing on what's the most important thing to do at any one time, initiating new ideas and activities, or conversely, knowing when it's time to stop trying something because that's not working anymore or that's not appropriate to say right now. All of those executive capabilities depend heavily on the frontal lobes of the brain, which is unfortunately one of the areas where brain tumors like glioblastoma most commonly grow. And for that reason, some of the most common symptoms people experience are problems with those reasoning, judgment, multitasking, impulse control, those types of skills. So understanding the individual's particular pattern of cognitive symptoms, strengths, weaknesses, and how those affect their daily function, that is the starting point, the foundation for understanding the problem, as I said. And that's what we do in a neuropsychological evaluation. But that's really just the starting point, because obviously understanding is good, it's better than not understanding, but it's not necessarily going to fix the problem all by itself. The reality is, and any of you who have lived with brain tumors or had family members or worked with people with brain tumors know some of these problems can't just be fixed. You have to work around them, you have to learn to understand them and compensate for them. And that's where things start to get more active in terms of our cognitive or brain wellness type of approach for people with brain tumors and other cancer. There are a number of different components to that strategy. Some of those include brain health lifestyle by maintaining the health of the remaining structures of the brain, which is critical for long-term good outcomes. And then there are more targeted approaches such as cognitive rehabilitation, the use of certain medications is sometimes indicated, and this is where we're trying to develop new strategies and directions to enhance what we can do to promote brain health for brain tumor survivors. So first I want to just talk a little bit about brain health. This area has grown tremendously in the past 10 to 15 years, driven in large part by the science that is helping us to understand what individuals can do to promote brain health as they age. The ability of basic lifestyle adjustments to stave off the effects of aging and reduce the influence of even neurologic diseases like Alzheimer's is really pretty impressive and rivals, at this point, the best treatments we have for those kind of disorders. Physical exercise is far and away the single number one most powerful thing that you can do for brain health. And that is true as well for promoting wellness in the context of cancer. Not just brain wellness, but also combating fatigue and reducing risk of recurrence, medication side effects, and other outcomes. So engaging in physical exercise, particularly aerobic type of exercise, seems to be the really driving force here. And I'll give you an example of one of the studies that helped us really understand how powerful an effect this can be. This is an image from a study not in people with cancer, but in healthy elderly people over the age of 70. What they did in this study was they put people into one of two groups, a walking exercise group and a stretching group. And then they basically guided them through an exercise program for a full year, with the walking program being very much like you would imagine it is. Nothing outlandish, 4 days a week, going for a walk 30 to 40 minutes at a comfortable pace. And the stretching group doing the same amount of time stretching. Over the course of that year, they measured the size of this structure I mentioned before, the hippocampus. And this is showing it here in yellow on a little slice of the brain, and examined the change in size over time. Now, in your 70s, the hippocampus loses about 1% of its volume per year as a function of natural aging. It's okay, it happens, we all survive it. But, you know, it's a normal but negative influence. I'm going to let you guess which group is the blue line and which group is the red line. The bottom line is that not only did the exercise group not have that decline, but their hippocampal volume increased by about 1% over the course of that year. This finding, which was published in a major scientific journal in 2011, has been replicated multiple times since then, and using all different kinds of exercise, proving to us that the key form of exercise for brain health is really this aerobic type of fitness. And it does not have to be, you know, Boston Marathon that you're training for here. Just building that in as part of your daily routine is probably the single number one most powerful thing you can do for your brain health. And that's true whether you have a brain tumor, whether you have Alzheimer's disease, any neurologic disorder. Exercise promotes brain health in that context. What about brain exercise or cognitive stimulation? The results for that component of brain health are also pretty convincing, though not quite as powerful as physical exercise. And that's because, you know, the bottom line from brain health is that it appears having cognitive engagement as part of your daily routine is the active ingredient. And that can take a lot of different forms, right? That could be puzzles and games. That could be learning some new information, continuing education. It can depend on your social interactions, a book club, a group like this. You know, all those kinds of cognitively stimulating activity, if you truly engage in them, seem to drive this kind of cognitive wellness. The computerized or puzzle type of approach is certainly one piece of that, but it is not necessarily the case that those activities, the brain games type of activities on the computer, are the active ingredient. Although companies may want you to believe that that's the case, and this is a graph that on the left here just shows the increase in market share of computerized cognitive stimulation activities over the past decade or two. And this is just a little news note from a few years ago in which Lumosity got their wrist slapped for claiming to be able to do things for people with Alzheimer's disease that they had never shown they're able to do. So, you know, it's certainly not going to harm you to do cognitive brain games on the computer, but that is not necessarily, you know, homework that you have to take home with you tonight, right? It is one option among many that can provide cognitive stimulation. So those are the key elements of brain health. There are many others, and I'm happy to take questions about those, like diet and sleep and stress management and so forth, which are also critical parts of brain health. But when it comes to helping people to deal with the cognitive symptoms and problems that come from a brain tumor or from other cancer and its treatments, we often want to be more active and specific. Cognitive rehabilitation is the most effective method for intervening to help somebody solve a cognitive problem they're having. Usually that involves kind of two things: compensatory strategies, in other words, learning to understand the cognitive problem and develop strategies that help you to improve it or work around it, and then also some of that cognitive engagement that we were just talking about. Within the MGB Cancer Institute, we have a number of different professionals in different types who provide this kind of cognitive rehabilitation for our patients with cancer and brain tumors, including neuropsychologists like myself and also our speech and cognitive rehab therapy team, which we are closely enmeshed with. They meet with people either individually or in groups to provide this kind of treatment. This is one of those groups that was just started this fall by my colleague Jenny Nosker. She is based at Brigham and Women's Hospital, which is now under the umbrella of the MGB Cancer Institute. And she's developed a specific group for cognitive rehabilitation for brain tumor survivors. It's a 9-week group program in which she walks the participants through a combination of cognitive strategies that you can use to improve your memory on an everyday basis, as well as improve attention, increase your executive functions like inhibitory control, cognitive flexibility, organization, and she builds in a few key concepts from clinical psychology that help to manage the stress and anxiety of these cognitive problems and prevent that stress factor from interfering with your cognitive function. There are a number of other programs that are newly in development and just starting enrollment as new clinical trials for improving quality of life and outcomes for people who are living with brain tumors. Dr. Deb Forst and Dr. Dan Chu, both colleagues of Elizabeth's and I, have developed a couple of programs that are targeting the psychological distress and its impact on brain function for people with different types of brain cancer. One of our sort of inventive and creative residents in radiation oncology is working with me to test out a new method for monitoring brain health for brain tumor patients as they undergo radiation therapy and in the months after. Essentially what this involves is a device that tracks eye movements. So you can see this subject over here on the left, who is sitting in the radiation oncology suite, is following the blue circle and then the red circle with his eyes. We're measuring a variety of features of the eye movement integrity at multiple times over the course of his treatment and then for up to 6 months afterwards in this new trial. The radiation therapy, which can help to control the tumor and improve cognitive function by virtue of doing so, as we said before, can also have both short-term and long-term side effects. And we're looking for ways to actively monitor who is staying nice and stable during treatment and who might be experiencing changes in brain function that could be a warning sign of something worse to come. So each of these subjects participating in the study will have their eye movements monitored weekly during radiation therapy, and we'll compare that to how their cognition is doing over the course of therapy and thereafter to understand whether we can develop new tools that would allow us to more quickly catch cognitive problems for people with brain tumors. One of the most exciting new directions, and somebody asked me earlier what I was most excited about in our group, it's probably this project that Elizabeth and I are co-investigators on with our colleague Georg Dietrich. Jörg Dietrich, in addition to being a neuro-oncologist, who I believe has spoken in this venue before, is a cell biologist who discovered that a commonly used drug in the treatment of many cancers called GCSF, granulate colony stimulating factor, which is used to promote the growth of bone marrow. This promotes the growth of bone marrow and helps to regrow blood cells for people undergoing chemotherapy. Also promotes the stem cell growth that can migrate from the bone marrow to the brain and differentiate into new brain cells. He proved this in animal work, and we are just starting our first trial to study whether we can use this approach to help protect or even regrow brain tissue in people who are undergoing treatment for glioblastoma. On the left is an image showing two brain scans from the same person at different points in time. This person had a brain tumor over in the hemisphere over here that was treated with radiation therapy. And 2 years after radiation therapy, what you can see is that their entire brain has started to atrophy. These fluid-filled spaces in the middle are called ventricles, which Elizabeth referred to earlier. Notice that they've grown on both sides of the brain, both near where the radiation was delivered and on the other side, showing us that brain cells are dying and making space for these fluid-filled spaces that just gradually expand and take over to maintain the pressure inside the brain. In a study in mice, Dr. Dietrich showed that injecting the mice with this granulate colony stimulating factor during radiation therapy caused new bone marrow cells to grow, migrate through the blood into the brain, and form neural precursor cells, which then grew into active adult neurons, integrated into brain networks, and improved the animal's performance on tests of memory. Between that early finding and the knowledge that this is a treatment that's commonly used for our patients with brain tumors and other type of cancers very safely, we were able to get approval for our phase 2 trial, which is now enrolling in our group at MGB, in which patients are being randomized to receive either the granulate colony stimulating factor while they undergo treatment or a placebo, and we're monitoring the health of their brain using a variety of advanced imaging tools that Elizabeth is overseeing, cognitive assessments that I'm overseeing, and blood cell measurements that we're looking at with Dr. Dietrich running the whole show. Our hope is that innovative programs like this can allow us to, until Elizabeth's Genius Therapy cures all brain tumors, and until that time we can hopefully find methods that will help people live with the cognitive symptoms or improve their cognitive function after dealing with a brain tumor. So just to summarize, as I think you know, the cognitive issues are common for people with brain tumors that relate to a variety of factors associated with the disease. And our goal in the Cancer Institute's Cognitive Wellness Program is to really try to help with those problems on a clinical level for each individual person who's experiencing them and develop treatments that will improve outcomes down the road. So thank you to all those of you who are attending here tonight and giving me your attention, to the patients and families who put their trust in us and come to us for care and participate in our research, and just a few of our colleagues here in the different departments that it takes to do this kind of work. Nope, stop there.
And we usually have some pretty good questions.
Mine's kind of a strange question, but all your activity is designed to cure people who have cancer, one way or another. And sharks can't get cancer. Is there anybody looking at why humans should get cancer and sharks shouldn't?
I think that's a cancer doctor question.
I'm sure there are people looking into it, but I have to admit I don't know the data on it, but I'm going to look into it and I will send an email to Bill with an answer for you.
Great.
I just have a question, because you put a lot of conditions up on the board and in your presentation, and I don't think I have a brain tumor, but I have a lot of those. And so it's just interesting to me that you're identifying those conditions, you know, loss of memory, going into a room and forgetting what you came in for, whatever. I'm fairly athletic, I stay well exercised, and et cetera, and yet I still have a lot of those conditions.
Yeah.
It's not really a question, but it's like,
Well-
why is that?
Yeah, yeah. Well, I think the changes in the brain over the course of aging are inevitable and not always pretty. Those kinds of cognitive slips that you're talking about are by and large a completely normal and inevitable part of aging. And part of what we do in a neuropsychological evaluation is to try to differentiate where do those normal age-related cognitive changes diverge from something that is more pathological. And the cognitive testing gives us leverage to make that determination in a way that, as an individual observing my own mental mess-ups on a day-to-day basis, I can't do with myself, right? Because that's what you notice, all those slips. The reality is once you start to focus on those, then all of the things you're doing right, they don't really get quite as much notice. And how your cognitive slips compare to the normal changes that you might expect to experience by your age, it's impossible to tell from the brain user's point of view. So the testing is super useful for that. And then, you know, with the combination of the test data and listening to what exactly you're experiencing, I can give you feedback about, here's where I see your cognitive performance looking very normal, here's where your strengths are, here's where your weaknesses are, and then ideally, here's what you can do about that. Or if I see something that's really concerning, like, yeah, that is more than just a normal age-related memory loss, I would probably introduce you to a neurologist who would say, okay, let's get a brain scan, or let's look at this kind of special biochemistry in your spinal fluid that can tell us whether you have a degenerative problem going on that's beyond normal aging. So starting with the symptom, using the testing, and then differentiating the problem to try to figure out what the next step is a lot of what the evaluation is really all about.
Thank you.
I was wondering, when patients come in with a brain tumor, are they automatically assigned to someone like yourself? And do they get your treatment along with the brain tumor treatment throughout their process? Is this an automatic thing, or is this special?
Well, a couple of answers to that. Not everybody who has a brain tumor will come to see me for an evaluation. In general, the problem, I would love to be able to do that. The problem is there's just too many people for me to keep up with. Basically the one, now we have Jenny Nosker, who I showed you a picture of, who's over at Brigham, who specializes in this area, but we couldn't possibly keep up with the 10 neuro-oncologists or whatever, however many you are, sending us patients. So at this time, for people who are experiencing a problem or are concerned, or there are certain groups of people who we try to get on board with as automatically as possible. For instance, people who are in the middle of their working lives when their brain tumor is diagnosed. Even if they're doing pretty well, even a subtle side effect on cognition could really be problematic for that individual. So we try as much as possible to see all of those folks. Going forward, one of the other areas of development is exploring methods that are sensitive and accurate enough to administer to people automatically, like computerized cognitive tests, that would allow us to, say, get a little red flag if something were changing over time. That eye movement type of exercise is one approach to that. We have another approach that we use that involves people taking tests on their phone or their tablet or computer that we're right now looking at in a subgroup of patients who have a disease called neurofibromatosis. Just trying to understand if it's sensitive to the right things and if it could actually pick up useful information, and then those people could be funneled to a more in-person assessment like mine. So part of the challenge, we're very lucky at MGB to have a I hope they think they're very lucky. Most cancer centers do not have a neuropsychologist dedicated to cancer. And there's very few of us in my field with the expertise and experience to be able to really understand enough about brain cancers and other types to be a good team player with oncologists and know when is my evaluation going to be useful, how long should it be, what do we need to look at. So I'm a little bit of a weird one-off guy anyways, and then there's the goal to expand our reach to capture and monitor and care for a larger percentage of our population over time.
I would say having Dr. Parsons join the team, he reminded me this, it was 8 years ago he came and joined our team, and it's really revolutionized the management. I just have the added value that he brings and the discussion he's able to bring to the patients, because previously I would send people for neuropsych testing, but I would just get a report. And these are long, very lengthy reports because what he does takes hours when he's evaluating patients. But I would get the report and I would have to share that with the patient. Now, what Mike can do is he has that feedback session with the patient and can talk to them directly and really explain to them what's going on. Because understanding the challenges that patients face helps the patient, but also really helps the caregivers so they can understand what they're getting into and what they're going to have to tackle going forward. And he can really pull together the team to support the patients in such an important way, both now with our current techniques and then in thinking through how do we do better down the road in the future.
I have one more for Elizabeth. In one of your early slides, you said in the clinical trial, 5 of 7 were something, and 6 people, and you said something about this is defining our success so far, and what I read was something like damage control, or what was the word that came in the line after that? Do you know? The question is, how do you define your success? Because what I saw up there was something that seemed rather vague to me.
Right. We're still early in our results. So we have 5 out of 7 people that we've followed for at least 6 months. So we still have more people that we've enrolled, but they just haven't met that 6-month mark yet. So what I know actually as of May, which was when we did the most recent kind of formal data analysis, is that 5 out of the 7 patients that we've treated in the recurrent glioblastoma arm have lived longer than 6 months, which is a pretty good benchmark to meet for recurrent GBM. We still have, one patient in the safety run-in cohort who he must be 2 years out at this point and is still alive. He's not included in that 7. But I think because we're still actively enrolling patients, I'm saying it's cautiously optimistic, but longer follow-up is needed because we need we need to complete the study, analyze it, to really kind of come back and say, we've hit our benchmark.
But 6 months, you would say 6 months is a pretty good benchmark of at least
of doing well.
Progress.
Right, exactly.
Thank you.
I'm just curious, we all have strengths and weaknesses cognitively. So say somebody's a big executive, great speaker, fluid time, but may have some weaknesses in math, for example. Are those predictive of what will happen? Are there generalized effects or localized to the tumor? And is that important to the testing or what you're doing?
Yeah, great question. One of the real limitations of the kind of testing that we do is, of course, we only get people coming to us once they're having a problem. So it's hard to know exactly like what did your pattern look like before this happened to you. The reality is, there's only so far before you can go, right? Because you've been living your life this whole time and things have been happening to you your whole life, like education, which improves some abilities, or brain degeneration, which decreases some others, and all of that is part of living. So we use a few tests that allow us to estimate. We call them hold tests. Hold tests are tests that tend to hold at the same level as where you sort of peaked from your education and your life experience, despite the progression of, say, some pathology like a brain tumor or Alzheimer's disease. Those hold tests give us a ballpark estimate of where to expect your broad level abilities to fall. And although everybody does have strengths and weaknesses, as you're saying, that gives us one piece of information to set an expectation about the ballpark we expect you to be in. We then also use other factors from your background, like educational experience, occupational background, and so forth, to get a feel for your strengths and weaknesses. Are you somebody who was always very verbal, a public speaker, or somebody who's very mechanical, like an architect or an auto mechanic? And we use those benchmarks then to compare to the pattern I'm seeing now on your assessment today, and then make some assumptions that are based on my understanding of brain organization and what to expect from a tumor located in this area versus that area, or a type of injury like radiation that may influence a broad range of brain networks and certain functions as a result of that. So it's a little bit of science, and it's a little bit of art, and it's a little bit of listening very carefully to understand the relationship between your strengths and weaknesses, the pathology itself, your current symptoms, and try to come up with a plan that's going to help. Which is part of why, I can't just put a tablet in front of you and say, here, do this mental test, and I'm going to do it that way every month or every year or whatever, and understand you as a person through that.
I get the sense that you're somewhat of a rare bird. And can you talk a little bit about how you're going to have a generation following on from you?
I'm so glad you asked that question. So one of the things that is a passion for me is exactly that, is educating the next generation of neuropsychologists about this field and the need that there is for people who do what I do to come into oncology and cancer, as well as educating the next generation of neuro-oncologists about what it is that a neuropsychologist can offer to the care of your patients. And by virtue of being at MGB, this massive medical institution with a main line into Harvard Medical School, I have a really tremendous opportunity to reach trainees in both fields. Also in the neuropsychology world, I frequently am giving workshops and lectures on this topic, and we developed a group, the largest neuropsychology organization. It's called the International Neuropsychological Society, about 5,000 neuropsychologists worldwide. So we started a group within there called the Oncology Special Interest Group that I developed along with a couple of my rare bird colleagues who do this work. And we now have about 250 members from our professional organization who are part of our subgroup, and we meet periodically to talk about these topics, have webinars and educational opportunities for our trainees and so forth. So we're working on it, trying to expand the reach of this. Probably Elizabeth and her colleagues are going to cure brain tumors before we get there. I hope so. Anyways, I'd be happy to not have to find help for that. But in the meantime, we are trying to grow our ranks.
Steve? Go ahead.
No, Alan took my question.
No. I have one. I did, with incipient, and you, I forget whether you called them arms or cohorts or what, the 3 lines, and one's fully enrolled, one has 6 to go, one has 1 opening or something or other. And then you have a lot of current patients to continue studying. The thought is sort of what's next. One is to complete the enrollment and do enough of that work, and then to complete each of those patients to, then what?
So we're hoping to launch a phase 2 study, and I think we have enough data to suggest that we want to proceed to the phase 2. There's enough signal there that we should open up a phase 2. The challenge is these are very expensive studies to do, and so one piece that Marcelo Maus and Brian Choi are doing as the sort of inventors of this CAR-T approach is trying to go out to venture capital companies to kind of they launched a company around this. And so their hope is that we can get VCs to be interested in funding that company so we can run the phase 2 trial.
Okay, any investors here?
I will say, just to follow up on that, the more creative aspects of the cognitive outcomes are also areas for funding, and we were very proud to be a part of Dr. Dietrich's NIH grant to support the study I told you about with the GCSF, which received a remarkable score from the NIH at the 5th percentile of all grants submitted. Unfortunately, we learned over the summer that they're now only funding grants that score in the top 4%. The 4th percentile, which is insane, right? That's the 4th percentile of scored grants. The top half, the bottom half of grants get triaged, so it's actually like top 2%. So, we're still hopeful that as times go forward, that grant, which was obviously very well thought of, would be funded and allow for paying for this drug and the imaging that we want to do and the blood studies we want to do to understand how it's all working. But in the current environment, it's very challenging to do this work.
Okay, thank you. Thank you very much.
Thank you so much.